And our next friend, John Millichap, I don't think anybody reads an EEG like you, John. And it's been a feature of our KCNQ2 conferences from the beginning. A professor at Northwestern University, somebody who's just been a stalwart friend of the community. We look forward to your presentation, Dr. John Millichap.
Well, thank you very much for the introduction. I've been reminiscing because the very first summit was here in Denver, I guess 8 years ago. And if you look back at the picture from then, I'm the only guy wearing a tie. And I think it might be the same red tie and suit. I need to go shopping. But I really have enjoyed coming to these summits and meeting new people, and I see a few familiar faces, but mostly new folks. So some of these slides I've had before, but I've tweaked them a bit with some feedback. Not too much into EEG, but I think by the end of this, I do expect you all to be able to read an EEG, or at least understand a little bit more about the report. So I am going to talk about seizures in general and epilepsy in general, kind of how we approach these things when we first meet a patient, whether they have KCNQ2 or not, and then focus in on the initial presentation you've already heard about from others with regards to KCNQ2 onset in the neonatal period, and then how that can evolve into other seizure types later. And I was asked to talk about the specific treatments that might be available right now. So I've pulled the available data that's published out there, and I'll give you my clinical experience as well. So as I said, I wanted to start off with seeing a patient for the first time in the hospital or in the clinic with a spell. Did they stare? Did they jerk? That somebody's concerned. And we start thinking, is that a seizure? Could be something else, but it might be a seizure. And if it is a seizure, what type of a seizure is it? And that can be very important because not all seizures are treated the same or have the same prognosis. And if that is a seizure, what is the potential cause? Or is there something called an epilepsy syndrome that we can diagnose based on that information? So Dr. Sheffer had mentioned that there's a group at the International League Against Epilepsy that meets regularly to revise the terminology that we use as doctors to describe these EEGs. This is the 2017 version. Don't have to read all of these, but just get the idea that there's a lot of terms that we use to be very specific about the types of seizures that children are having. And the main pools are focal, generalized, or we don't know. And if your doctor says they don't know, it's not because they're not a good doctor, it's because maybe there isn't enough information available at that time to determine how the seizure might actually start. And in very small babies, most of the seizures will be focal onset rather than generalized onset, typically because the two halves of the brain aren't, the wiring isn't fully developed. And once you have the seizure type, then you can move on to yet another slide from one of the publications from Dr. Sheffer's group at ILAE, looking at the epilepsy types. So once you have focal seizures, then you might be considered to have focal epilepsy and generalized seizures, generalized epilepsy, and some can have both focal and generalized seizures. And when you look at all the comorbidities, which are the things that go along with the seizures, and the underlying cause, whether it's an infection, genetic, or a stroke, then you might be able to get even more refined in your description of that patient's epilepsy. Or you might zero in on an epilepsy syndrome. And I'm really happy to say that 8 years ago, compared to 8 years ago, genetic testing is now really something that many pediatric neurologists will use when they're trying to determine what type of epilepsy patients have. I would say back then it was done very rarely and only in cases where we really were down the road quite a bit and there wasn't a good cause known. EEG and MRI is almost always performed, but now I think genetic testing as well. And to focus on EEG, my favorite test, I think it's very useful in the KCNQ2. It can support the diagnosis, as I'll describe. And once the diagnosis is already made in KCNQ2 and other types of epilepsy, it can determine whether new spells are seizures or something else. And if there are new seizures, what type of seizures they are. And there are also other non-seizure related uses of EEG. Has the child had some developmental regression? Is it because there's been some change in their metabolism? Maybe the pediatrician added an antibiotic, which made the anti-seizure medication levels go sky high, and now the patient is half asleep and can't do their therapies. Or is something going on with their epilepsy? Have they had a worsening of their encephalopathy? So the EEG can also look at the background activity. Or to confirm improvement. So when we think we have all the seizures under control, sometimes it's a good idea to do an EEG to confirm that information. Sometimes seizures can be very subtle and won't be seen by the naked eye or be missed, or might occur when families are not observing their children, such as when they're sleeping. So EEG has a lot of uses in the management of KCNQ2. So here's the minimal 101 on EEG. So what is the EEG background? So when you read EEG background or your doctor talks about EEG background, they're talking about what the EEG shows in between seizures. And this is different for babies, 5-year-olds, 10-year-olds, 60-year-olds, 80-year-olds, when you're awake, when you're asleep, when you're relaxed. These things all affect the EEG. So I think pediatric EEG is much more interesting than adult EEG because we have to know what is normal for a 2-month-old, a 12-month-old, a 3-year-old, because it's all different and constantly moving. And it can be normal, have the normal amounts of activity in the parts of the brain that we expect in the different states, or it can have some abnormality that we usually refer to as slowing. So here's in this figure, you can see the different frequencies of the activity. At the top, we call it beta. It's very fast activity. You can see the numbers of ups and downs of the waves is very high every second. And then at the very bottom, we call it delta when it's very slow. And if you have abnormally slow activity in one area of the brain, we call that focal, so it may be right here above your ear, or if it's diffuse, kind of all over the brain, that would have different clinical importance. And now the spikes. So an EEG may have no spikes. Some children with KCNQ2 as they get older may have no spikes at all, hopefully. And but others, when they're first born, will have a lot of spikes. And they can be described as either looking alike or all looking different from each other. And generally, the spikes looking alike is a better prognosis than those that all look different. And here's a picture of what spikes might look like. They can be a little bit wider, they can be a little bit narrower, they can happen together. But basically, it's something that sticks out from the background, looks very different from slowing, and looks like it might hurt to sit on, is one description. And again, is it in one area of the brain, or is it all over the brain, or are they happening on both sides of the brain at the same time? Also called generalized. So my mentor, Doug Nordley, took a sabbatical, and he said he was working. He figured out this easy way to apply those patterns I just described to you with spikes and backgrounds. So even though we do record seizures and try to characterize epilepsy that way with complex interpretation of the seizures, sometimes we just need to look at wake and sleep in that patient in order to have a good idea of what's going on. And you can make these 5 types based on the stereotyped or pleomorphic spikes and the background activity. We'll be focused on type 4 with pleomorphic, multifocal, and diffuse spikes and diffusely slow background that most commonly occurs in KCNQ2 DEE. Now, this is applied with some more data. So the age of onset. So did the seizures start in a neonate? Did they start in a child? Did they start in an adult? And these things can help us narrow down into some of the epilepsy syndromes. So those very small print, but in those little boxes are some of the epilepsy syndromes that Dr. Sheffer was talking about earlier that have been described by the International League Against Epilepsy. And so even just with those 2 little pieces of information, the background activity in wake and sleep and the age of onset, we can narrow things down. And so if you look in the red box in neonatal onset, you'll see Ohtahara syndrome, which many patients with KCNQ2 DEE are diagnosed with initially. And the other KCNQ2 phenotypes have been described by Dr. Sheffer earlier. The self-limited familial neonatal epilepsy, the name has changed from benign since this figure was made. And some of the other diagnoses, West syndrome, also known as infantile spasms, for example. So back to Dr. Ohtahara, he was studying EEG and epilepsy and first described Ohtahara syndrome in the 70s. And this is a figure from his paper on the subject describing burst suppression, which is an EEG description that is used a lot in the initial presentation of KCNQ2 DEE. And you can see the bursts of activity here and in between relatively suppressed, meaning the voltage is low. So even if you don't read EEGs, I think if I show further examples of this, you'll be able to pick that out and maybe make that diagnosis. This is maybe what I see more often with kids with KCNQ2 DEE in the initial period. It'll be somewhat discontinuous. You can see here it gets a little flat for a while, but it doesn't have that same periodic suppression. And you all were already diagnosing all the spikes in multiple areas of the brain, so knew this was multifocal spikes. And all the spikes look different, so they're pleomorphic, right? So this EEG is consistent with KCNQ2 DEE type 4. So I'm going to present a case of neonatal onset seizures to illustrate the type of seizures that might be seen. If anybody's squeamish about infants and seizures, I just warn you that there will be one displayed here. This child was born in term with no initial concerns, not at our hospital, but several hours away. And on the 2nd day of life in the nursery, the parents noticed some events that happened with feeding. And these were described as whole body stiffening, head going to one side, crying, heavy breathing, and perioral cyanosis, which means turning blue around the lips. Pretty scary. But only the parents, and saw it, and the mother saw it. And when they described it to the nursery staff, they said, "Oh, maybe they were choking a little bit on, breastfeeding or something. Nothing to worry about. Why don't you go home?" So went home, and thankfully the experienced pediatrician saw one in the office, or the nurse in the office saw it, and said, "That's not normal," and sent them right back into the hospital. Where they had this EEG done. And now everybody in the room knows, what does that show? Is that normal? No? Everybody's shaking their head. Okay, great. You guys already can read EEGs. Congratulations. So you know that this baby is in trouble and needs some help. So even without recording those spells, we already know this baby has problems and needs to be treated and diagnosed, or diagnosed and treated. So they went on for several months at the local hospital, trying several medications, up to 3 or 4 medications. Went for a second opinion somewhere else, but were having 25 seizures a day. They came up to Chicago and at a couple months of age, and we admitted them and recorded this seizure. You can see the baby turning, crying, turning blue. And I'll say that sometimes when we hear this scream, it really is somewhat specific for these focal tonic seizures in infants. Even children with other ion channel related epilepsies, like you've heard SCN2A mentioned, SCN8A is another one. That type of seizure, they look very similar and sometimes point us towards some ion channel related epilepsy. I have the EEG segments here, so this is in order from top to bottom. The beginning of the seizure, you can see the EEG kind of goes flat with the tonic seizure, and that black stuff is just the muscle activity. If you put your hand on the side of your head and clench your teeth, you can see that you have muscles that overlie your skull, and when those are activated, it shows up as artifact on the EEG. So as an EEGer, I have to sort of filter that out with my brain and see that's not brain activity. And then in the bottom segment, the seizure is ended. So even before getting the genetic testing result, I had a good idea what this was just after talking to the parents, and gave IV phosphinatoin, and the seizure stopped. And we started carbamazepine orally, because phosphinatoin is very difficult to keep a good level in a baby. And weaned off the other 3 medications that had been ineffective over the coming months, and there have been no seizures for several years. Unfortunately, as 6 months, a year came for this family, the development was not hitting the milestones, and despite being seizure-free and counting that as a blessing, there were developmental challenges still for this baby. The KCNQ2 variant had come back within a couple of weeks after the initial presentation here at a couple of months. So just a summary of that case. So 2 days events with feeding, video EEG confirmed seizures at 7 days old, and there was suffering for 2 months with 25 seizures a day and multiple failed medications until the genetic diagnosis was recognized and started the effective treatment. And the genetic testing comes back with the KCNQ2 diagnosis. So becomes seizure-free after personalized therapy or precision therapy, if you want to use that term. So really earlier genetic testing would have confirmed the diagnosis and changed treatment. So I think even since this case has occurred, there's free genetic testing, and more pediatric neurologists and hopefully neonatologists are taking advantage of genetic testing, and if there isn't a known cause of epilepsy, are getting to that diagnosis and changing treatment. And there's been obviously my clinical observation of the response to sodium channel blockers, but then this is one of the larger cohorts describing the effect of sodium channel blockers, effectiveness for KCNQ2. There were 15 patients described here, and in those patients who were looked at retrospectively, carbamazepine and phenytoin were the most commonly used and effective medications. And the results suggested that drugs with sodium channel blocking activity should be considered as a first-line treatment. So some later seizures. This case will describe a patient who also presented in the first couple of days of life, but was born much earlier, actually 2010. So this is really before we knew what KCNQ2-DE was. We knew what KCNQ2 was, but it had only been associated with the self-limited benign form at that point, and wasn't really on the radar of doctors thinking about causes of neonatal epilepsy. Also had focal tonic seizures, also had the burst suppression, and seizures initially responded to the phenobarbital, but then continued and became refractory or not responding to any medications. All the tests were done, and back in those days we sent many blood tests, urine tests, spinal taps, repeating MRIs, and doing genetic testing one gene at a time. So now we talk about panels that have 300 genes on them. Back in 2010, we would do one gene, wait 2 months, 3 months for the result to come back, then do it again, wait 2 or 3 months for the result to come back. So that wasn't that long ago. So we've really come a long way for helping these kids. So this child was having continued seizures, which evolved into a different type of seizure called infantile spasms, which I'll talk about later. And these infantile spasms then evolved into brief tonic seizures, which continued for many years for this child. The child had intellectual disability, unable to walk, and had low tone. And when we finally got to KCNQ2 in our list, when the paper from Dr. Weckhuysen came out describing KCNQ2 DEE, we found that this patient had one of the same variants that was described in that paper. Just a representation of what the EEG looks like at birth. You saw that picture. And then at 2 months old, it starts to become more continuous. So the EEG starts changing even in the first few months of infancy, where it becomes more continuous, but you can see that there's still multifocal spikes present. And the seizures that were occurring at 2 years of age, for example, here. Now, if I tell you that blue line at the bottom is what we call an EMG or electromyogram, this is usually put on the right deltoid muscle or right on the right shoulder, and that picks up any stiffening that the child might be having and will help us pick out stiffening type seizures or jerking type seizures. So you can see here that the EEG changes slightly. It gets lower in voltage at the same time as the stiffening occurs. And similarly, at other times in the day, usually when falling asleep, the child would have clusters of epileptic spasms. So basically an epileptic spasm is more or less a very short tonic seizure that usually occurs in clusters. So they look very similar as far as EEG-wise and as far as the EMG. Here's a video of still having these brief tonic seizures at 7 years old. So while he's laying in bed trying to sleep, he'll often have clusters of these where he outstretches his arms. I'll say that earlier, when this child was under a couple of years of age, was not getting regular video EEGs, the parents noticed that the child would have startles as falling asleep and didn't really recognize them as seizures, didn't bring them to medical attention, and without video EEGs being performed, was considered not to be having seizures, was just having the short 20-minute routine EEGs performed. So there were these brief tonic seizures occurring for many years, and they were actually unrecognized for quite some time. But they have been a challenge to treat, and really affected his ability to relax and to sleep was the main drawback to them. Thankfully, they're very, very short. So there isn't a lot of information out there regarding seizures and the best medications beyond the reports I've given you and my clinical experience. This was already described by Dr. George, and Dr. Paturi is talking after me, and Dr. Berg is worked with us at Northwestern for many years. But she developed this natural history study online platform and collected these data from parental reports. And there were 39 children who met the inclusion criteria. And I just put this slide up to show that there children 2 years and older made up the majority of those who responded, so 28 out of the 39. And many of those were still reporting seizures. So I think just as I see many new faces, and I don't see a lot of the old faces here at the conference, I think those who maybe continue to fill out the surveys and so on might be those parents of children who are continuing to have issues. So the data, we don't have maybe the survey data from many more kids whose seizures may have stopped by 2 or 3 years of age, but this might be a little bit skewed to those who are continuing to have those seizures. These were the seizures that were described, and these are the medical terms that we used that you saw in the initial ILE classification system, but the parents were given non-medical terminology and descriptions of these seizures when they were asked to say whether their child was having them. But they may not have been necessarily diagnosed by their doctor, but seemed like what to the parents was the type of seizure that they were having. Tonic, clonic, and clonic were the most common. Infantile spasms and myoclonic and focal motor were described in a few, and behavioral arrest and absence seem to be rare in the group. And as far as treatments, so this was one of the representations of the treatments, and this was the general. So if the parents were asked, over the life of the patient, how was the response to these medications? So this would be a general effect for all seizures, not specific seizures. And I'll say that because there's some medications in there, ACTH, or you see VGB, ACTH, and PRD in the acronyms there. Those would be specific for infantile spasms, for example, which I'll talk about next. So some of these medications may only be expected to be helpful for certain types of seizures. So the main message I got from this excellent representation here was that the most effective and most common medications were the sodium channel blockers, such as oxcarbazepine, phenytoin, carbamazepine, and topiramate. Topiramate came out when I was in training and around 2007, and we used it a lot because it works in many different ways, about 5 different mechanisms. One of being sodium channel activity, and I've over the years heard of many kids with KCNQ2 who have responded to topiramate because it is used sometimes in very young infants, or has been for many years. And good effect, but limited data here, only a few patients described with sodium channel blockers, lamotrigine, and then the newer medicine, lacosamide, also known as Vimpat. So this paper was already previously presented, where there are gain-of-function variants that result in patients with infantile spasms as the initial seizure type. So kids who don't have neonatal seizures. Just to summarize it, there were 4 kids with infantile spasms. They came on at the typical time, around 6 months, without neonatal seizures. These occurred in clusters, and there was hypsarrhythmia on the EEG. I'll describe what hypsarrhythmia is in a second. And they all had the same gain-of-function variant, and they all eventually became seizure-free in the time that the data was collected with moderate to severe delays. But that's not to say, as you heard with the second case, that kids can't develop infantile spasms after having neonatal seizures. And this is just an observation comparing those 2 cases. The baby who received treatment with and stopped seizures at 2.5 months got the carbamazepine started, and the seizures stopped, did not develop infantile spasms. But that other child, the second case, who developed later seizures, didn't get that early effective treatment that stopped seizures. So maybe in that second baby we did better and maybe adjusted how the outcome. So this is a representation of hypsarrhythmia, sort of similar to burst suppression in clinical practice. There's a textbook picture of hypsarrhythmia with very high voltage, disorganized slowing with multifocal spikes. But sometimes we have variations of it. Sometimes the voltage won't be quite so high. Sometimes it'll only occur in sleep. But there's always an abnormality, always multifocal spikes. So your doctor might say there's modified hypsarrhythmia, but I hope that they won't miss the diagnosis of infantile spasms because they say it's not hypsarrhythmia, it can't be infantile spasms. And here's another video of an infantile spasm in a child who doesn't have KCNQ2, but from the infantile spasms community of available videos of infantile spasms, and a very classic picture of what the EEG looks like when that spasm occurs. It goes completely flat. You can't really miss it when you're reading the EEG. And there are 2 FDA-approved treatments for infantile spasms that I mentioned before. ACTH is a steroid-type medication. It actually stimulates, it's a hormone that stimulates the body to produce its own steroids. It's given as an injection twice a day for 2 weeks and then once a day for 2 more weeks. Some very good centers will use prednisone instead of ACTH because it can be given orally, but that hasn't been tested and FDA approved for the treatment of infantile spasms. Vigabatrin is a medicine that's given by mouth and is a regular anti-seizure medications. Adults also take it for focal seizures, but was discovered to be very, very effective for infantile spasms. It's a dissolved powder, so it can be taken as a liquid form, and typically the treatment, if effective, is 3 to 6 months. Both of these have serious side effects that need to be weighed, and the choice between the 2 of them depending on the individual child. But in many cases, both are given together to get the best outcome because only about 60% will respond to the first treatment and will require the second one, which then increases the response rate to about 80%. So some centers have started giving both of these at the beginning so not to waste any time getting seizure control. So even though patients have KCNQ2, I still would recommend using the FDA-approved treatments for infantile spasms if that seizure type were to occur. So in conclusion, I think the diagnosis, and then if the diagnosis is already made of epilepsy, if something changes, if there's a new spell, I heard already from a attendant here, or a mother attending here, that there was a new spell. They asked their doctor about it, and they immediately got in for a video EEG, and they're waiting to hear the results about whether it's a seizure or not. So that's excellent advocacy for their child. And we really need to educate all of our neurologists, geneticists, neonatologists about KCNQ2 so we can get the sodium channel blockers started in that neonatal period and get the seizures under control. And lastly, later seizure types may need specific treatment, especially infantile spasms. And I hope as new drugs are approved, we'll have more information about the next best treatment in different situations. Thank you very much for your attention.
Does anybody have any questions? Do you have any questions for John? Yes, we have one there. Yes, it's for the online audience.
Just a quick question about new episodes. So obviously, I understand that you have the abnormalities on the EEG at birth and the burst suppression and the hypsarrhythmia, etc. And then the seizures like maybe settle down, and then you get my son's had 2 episodes of possible impaired awareness seizures, having been seizure-free for 2 years. But there have only been like 2 episodes. So if I get an EEG and we don't have one during that time, is it going to be completely useless, like as far as helping us? Like, is it like an ECG with a abnormal heart rhythm? Have you got to capture that moment on the EEG, or might there be other parts of it that give us some clues?
Right, great question. So sometimes we are unable, if they're not frequent enough, we're not able to catch the spell on the video EEG. But at least looking at the background activity can give us a comparison to what it looked like before. If there were no spikes, the last one that you did. Right, so, I think you just said that that was at 4 weeks old. Yeah, 3 years ago. So I think that's another, there's an art to medicine. There's no strict guideline about how frequently we should do EEGs, but as I mentioned in the introduction, doing EEGs when things are going well can be helpful as a baseline for when things are not going well. So if a child comes in having many seizures, has gotten a lot of medications, and is not conscious, for example, when we hook up the EEG, we can see whether the EEG is similar to what it was when they were doing well, or it's much different, and then that can guide our treatment. But to answer your question, I think if there's been a new spell, I think getting an EEG, even if there's no chance or a very limited chance of catching a spell, can still be beneficial. Maybe you'll be surprised where there's smoke, there's fire. Maybe there's smaller seizures not even aware of.
So I just wanted to get your perspective. We have just about 18 months of seizure control with our daughter, and are beginning the conversation as to approach with medication long term. And I've heard from some people that they discontinue the medication because the assumption is they'll outgrow the seizure activity. Others have the perspective that, if the medication is not bothering the child, just to stay on it, for the long term or for a few more years. And I'm not sure if there's any research kind of one way or another in regards to seizure control, given KCNQ2 and how it presents, or what your thoughts are in that regard.
Right. So there's no specific paper or study that tells us what to do in this regard. I think in all patients with epilepsy and pediatric epilepsy, every 2 years of seizure freedom, or after 2 years of seizure freedom, we might reevaluate, do the tests, EEG, or whatever is appropriate to assess the risk for having a seizure off medication. And then at that point, have a discussion with the family about, generally, if we toss a coin, or if we say there's greater than 50% chance of having a seizure in 6 months, then we might continue it. If there's a less than 50%, then we might give it a try off. With KCNQ2, I've had many patients who had more severe onset, had developmental delays, but were in the middle of the spectrum perhaps, or even towards the more severe end. And their EEGs normalized, say by 3 years old, and they're no longer having seizures, and they were able to wean off the medications. But I think I used the serial EEGs as a clue, and if there were no spikes and no seizures for several years, then I would perhaps give that a try. I don't think there's anything that would say continue it for lifelong.
Can I just ask one more question on that? For example, our daughter has a normal EEG, but she did have seizures. Do you see that as well, where sometimes you're not going to necessarily get the answer from the EEG?
Yes, so having a normal EEG in between seizures is not a guarantee, but it does lessen the risk. And it's something in children that we might try coming off the medication just because of the benefit of the medication and the risk of the medication. We have to weigh those two things. If the child always goes into status epilepticus, has very long seizures, then the risk of coming off the seizures of medication may be higher, and in that particular instance we may stay on the medication. Or if they relapse later after being off the medication, we might, or if they have breakthrough seizures with a normal EEG, we might continue the medicine at that point.
Like one little follow-up question on that amazing question. There's definitely a belief in the community that the anti-epileptic medications might have an adverse effect on their development. So then there's this constant debate in the internet space, I suppose, where people want to come off medications because they think that maybe their child's development is slower because the medication is affecting the development, but obviously they don't want them to have seizures. Do you think that being on like a sodium channel blocker might have an adverse effect on that child's development, because that's the fear, or do you think that development is going to be unrelated and more related to the encephalopathy process, and therefore that isn't really a real fear, it's more looking at the seizures?
So that's a complicated question, and I think that all of the seizure medications cause some level of sedation. They all are designed to slow down the brain and slow it down to a point where there aren't seizures, so it's reducing excitability. We have to find that point where it doesn't affect function. So there's, if an adult took one of these medicines, you might be able to feel it. You're obviously not going to be able to ask a child, how do you feel? But they may not be able to do their work as well or remember things as well. There's very, very slight changes there. But having a lot of seizures is certainly not, in my opinion, a alternative to that balance of maybe a slight sedation.
All right, thank you so much, Dr. Millichap.
Sure.